Hello, hello, hello. Happy Friday, everybody. Welcome to another version of RLR on Friday. I was actually going to do the exercise of trying to figure out how many Fridays in a row we've been doing this, but it's a lot. Almost as many as the number of CP Solvers Academy members we have behind the scenes hanging out and joining early. I'm really, really excited to welcome first time case presenter, but with a sneak preview, apparently a longtime CP Solvers consumer, Hugh Larkin, to the case presenter seat. Hugh, tell us a little bit about yourself.
Yeah, I was recommended the podcast during must have been like the peak COVID times. One of my colleagues, when I was in my first year of training as a doctor, recommended the clinical problem solvers. And at that time,
Mm.
when you're a first year doctor, I mean, I'm sure everyone has a similar experience. You have this kind of feeling like you have a vast knowledge, and then suddenly you know nothing. And I was desperate to try and keep learning while I was working. Um, and I just thought it's great. I love the schemas. Then obviously VMR came along. It's just such a good way to just constantly check in with your own learning, keep, stay familiar with good medicine. Sometimes we get so swamped with
Yeah.
the day to day of the job, and you lose your positivity and you lose your momentum and your passion. And so this has been a huge part of the reason why I enjoy medicine and why I went into training in general medicine in the UK. So I'm a big fan. I'm delighted to come and present.
It's amazing. I feel like I've developed the ability to recognize one of our very own, and everything that you said just resonates so deeply with what this community feels and does. Both the aspects of joy that this place brings you, but the peace from the reprieve from the chaos of medicine. So I feel like even though it's a first time case presenter, I feel your long-term presence in this community. It's really, really cool. Tell us a little bit about yourself outside of medicine.
Oh, I mean, look, I'm nothing spectacularly interesting. Things I like. I'm getting married in September. That's exciting.
Oh my gosh,
Um,
that's spectacularly interesting.
well, my fiance is much more interesting than me. Um, but I guess my hobbies include things like I love running, so I do long runs in the mountains in the UK and Ireland. We're very lucky to have very
Oh
beautiful
my
mountains. They're not as high as in the States, so it's not as difficult. But I
God.
love getting outside, and you can digest your stress very well when you do exercise and just absorb the outside world. So yeah, that's kind of the only slightly niche hobby I have. Otherwise, I'm pretty bang average doctor.
Yeah, same here, my friend. I just came from a glorious run this morning, myself. I love to run in the outdoors, and to Prof Rez's great joy, I occasionally fall and bonk my head or hit my hand. I say that because Prof Rez is here. Prof Rez, we are welcoming Hugh, first time case presenter, but a long time clinical problem solver from the UK.
Hello, hello, hello. Good morning, everyone. Very excited to be here and looking forward to co-discussing. Sorry if the energy is a little low. I just woke up from a nap.
Wait, you just napped now?
I nap now.
Oh man, Prof Reg, you're unpredictable. Amazing. Well, I hope was it a restful nap, I hope?
Very restful.
Amazing. I have a sneaky suspicion that Hugh's gonna jolt you out of his sleep with a really cool case. We'll see. Um,
I welcome it.
well, Prof Reg, feel free to tackle the first aliquot, and Hugh, we're ready for you to jump into the case whenever you are.
Cool. Okay. Well, let's give it a go. I think what we should start with is a bit of a a 22-year-old male attends A&E today with a fever and chest pain. Um, he's There's no significant past medical history. He's been unwell for the last week with fevers, myalgia, and a sore throat. And for the last week as well, he's been using what we call paracetamol over here. Um, just for 1 week, and he's been self-managing. But today he's decided to come to A&E. And that's the first aliquot.
I love your accent. I'm sure I have an accent to you. I always wonder, like, do Americans have accents? Yeah, we have to. It has to be different than the accents. But we're all so self-centered that I felt like everyone else has an accent, but we speak the normal language. This is very interesting case so far. So we have a young patient, previously healthy, who's coming in with acute onset fever and chest pain. I think first and foremost, we take that fever, we're going to, of course, get a temperature, but with that fever, you can't translate it to inflammation. And the question becomes, where is the inflammation coming from? And truth be told, if Hugh gave us the entire presentation and excluded 2 words, I would be calm right now and relaxed. And those 2 words is chest pain. So like take out the chest pain from this story and say a young patient is coming in with sore throat, myalgias, and fever. What would be prioritized would be a viral syndrome, specifically infectious mononucleosis, or strep throat or viral pharyngitis. The thing that changes that for me is the chest pain. This is where all of a sudden I'm thinking of all the other findings, the sore throat, the myalgias. The myalgias are less specific than the sore throat, but I'm translating the chest pain and inflammation to an inflammatory thoracic process. And it's really important to make that leap in your brain, because now you can ask the question, what can be inflamed in the chest cavity? And the structures that can be inflamed include the lung, which definitely we've all seen patients with pneumonias who have pleuritic chest pain. The heart you have to be a little cautious about, because the heart has multiple components to it, from the valves to the myocardium to the pericardium to the coronary vessels. So any of that can be inflamed. And then other mediastinal structures can lead to an inflammatory thoracic signature. But here, I think you got to explore the sore throat a little more and think about, how can the sore throat link to chest pain and what are complications of sore throat? For that, mid-bite, I'm going to give the mic to Rabih to swallow quickly and share his thoughts. You're muted. Either you're muted or you aspirated.
You know, so we know what I was saying, Prof. Rez? I was apologizing for being unmuted and chewing my food loudly while I was actually muted. But anyway, I love the way you did that little translation. You know, you said patient has fever and chest pain, and this is an inflammatory thoracic syndrome. And the clarity that one gets with that is very powerful. And yeah, you're right. I think in real time, you would probably be, even at this point, authentically trying to be like, how can I connect the sore throat to the chest? And I think that the easiest way to connect them is a simple one, to realize that they're part of a systemic disease that's underlying both of them. So there's something systemic going on that is going to the pharynx and going to the chest. That is one way that you can draw an indirect connection. The other way that you can draw an indirect connection is to have not something underlying the disease in general, but to something that overlies the disease. Now, what do we mean by that? We mean something that a connection that is introduced by the outside world, namely us. So is there a treatment that was introduced that connects the sore throat and the chest pain? And so one could think of many medications that can result in this combination, but that would be a stretch in real life. Then, in addition to speculating what connects them indirectly, either underlying or overlying, is the possibility of a direct connection. And that direct connection between the upper and lower airway can simply be because of an upper respiratory disease going down the airways in the form of aspiration. But there are two other ways that it can go down deeper that are less gentle and more sinister. And that's going down the vasculature, usually in the form of septic thrombophlebitis in the IJ, or much more sinisterly than anything else, going down through the dead zone of the mediastinum. So what can happen is a sore throat can become a retropharyngeal abscess, which can then go down straight into the mediastinum, as there is no specific fascia that limits it from doing so. So said simply, Prof. Rez, I think the overlying concept in clinical reasoning of connecting anything is to wonder, is there an indirect connection underneath or above? Or is there a direct connection? And here, the direct connection is either through the airways, the jugular vein, or through the mediastinal space being contiguous with the retropharyngeal space. And I think this patient, this combination of symptoms is very, very alarming. I really, really think in real life, a careful attention to how ill he appears is going to be very, very important. I think you've woken up from your nap, Prof. Rez. I definitely have been jolted awake. All right, Hugh, Mike to you.
Very nice. So I'll go on a bit more history presenting illness. So he's been unwell for a week, but this morning he noted that the chest pain, which had been quite mild, has been getting worse. He feels the pain mainly over the left lateral chest wall and says it feels sharp when you ask him. Initially, this morning, it was intermittent, but this afternoon it's become constant. He says it's 5 out of 10 in severity. The pain isn't exertional, or made worse by exertion, rather, but it's worse when he takes a deep breath in. It's not worse when he sits forward or when he lies flat. There's no radiation of the pain to his back. It doesn't radiate up his neck or down either of his arms. And in the last few months, he denies any history of weight loss or night sweats. And to be honest, before this week, he said he felt like his complete normal self. He doesn't have any past medical history. He doesn't take any medications regularly at home. He doesn't have any allergies. And there's no family history of any significant medical or surgical issues that he's aware of. He lives with his friend in a shared apartment. He grew up and attended primary and secondary school locally. He works as a bartender. He smokes between 5 and 10 cigarettes a day. He rolls his own tobacco. He occasionally smokes cannabis, about 1 to 5 joints a day. There's no history of intravenous drug use. He is a heterosexual male who has not been sexually active in over a year. There is no history of recent foreign travel, and he's never been homeless. And that's the end of Aliquot 2.
You I'm just so intrigued by the richness of your history here and the very important focus on the social history and the modifiers of the pain. I'm curious, can you tell us a little bit more? Where do you work now?
Yeah, so I work in North London. We have in our hospital, of course, in A&E and on the acute medical take, we see a lot of patients, a lot of young patients, and we have a real diversity in socioeconomic situations. In the National Health Service in the UK, it's vastly different to healthcare in the States, as I'm sure you're all aware. And I think one thing I think about in young people who don't have risk factors to attend hospital late with significant illness, I always try to actually press and ask them for information which they may be holding on to and may, for whatever reason, whether it's a mental health, whether it's fear of judgment, whether it's fear of their friends or family finding out any sort of information, I always try and ask them questions in a way that won't make them feel like in a way that they may not find offensive. And I think asking about homelessness and asking about drug use in young people, based on my experiences in respiratory medicine here in London, is so important because it completely changes the dynamic. I think a good example is in infectious diseases. When you think about patients who have a transplant or patients who are on immunosuppression, your differential diagnosis lurches completely from what you otherwise would expect the common conditions to be. And so for a young person with chest pain, I think about the amount of anxious young people who we see in A&E, who you end up finding no cause for their symptoms.
Yeah.
This obviously isn't the case with this person, but asking about risk factors is absolutely critical for this, I
Yeah.
think.
I think you said it so well, way better than I could ever. And I think you've also demonstrated that here. In addition to touching on things that may be taboo, especially for younger people, I think the thing that has helped me get a lot of clarity on this syndrome is the fact that you definitively established that there isn't a long tail of this, that this is a new thing that has sprung up upon the person, which I find very, very valuable. So I think what's changed for me, big picture, is the confidence that this person does not have something overt that preceded this, but the humility that many patients can have subclinical vulnerabilities that they may not be aware of. And so while it is unlikely that this patient has wildly metastatic cancer, for example, it's still possible that this patient has an underlying immunodeficiency that may have not been manifested so far. But I think the threads that have emerged, in addition to the theme of understanding this patient's context better, is the dimension of focal pleuritic pain and the social context. And so, to return the favor, mid-sentence, I'll throw the mic to Prof. Rez for him to reflect on those dimensions and anything else he wants to.
Yeah, I thought that was fantastic, Hugh. Thank you for sharing that. And I can listen to you speak all day. Really, I can. Robbie, I think being authentic to the exercise here, those two words, chest pain, was what was most concerning. And here we have a qualifier of the chest pain, which is pleuritic chest pain. Because anytime that chest pain worsens with movement of the lung, that's referred to as pleuritic chest pain. And you always have to think about the P's of pleurisy in all patients. And that includes pulmonary embolus, pericarditis, pneumonia, pleuritis. So in anyone coming in with pleuritic chest pain, I have like such a low threshold to get a CTA, to get a troponin level, because we've even seen dissections present with pleuritic chest pain. So I think chest pain itself is a concerning finding, but we've all encountered patients who have chest pain, and it's unclear. Is it the chest? Is it some GI? It's like a slow onset. In this young patient, previously healthy, who has chest pain with two qualifiers, fever and pleuritic, you have to have a low threshold to pursue advanced tests, understanding that you are going to expose them to radiation, but it's well worth it. So I think what I would do next, in addition to an HIV test, which will be critical, will be the physical exam, but I'm not sure anything on the physical is going to keep me from, pursuing cross-sectional imaging, evaluating for pulmonary embolus, getting an EKG and troponin.
Lovely. Are we keen on hearing the next aliquot?
Very keen, honestly. I cannot wait to see what the signature of this disease is on the patient's body. It's, I think, going to be very, very telling.
Cool. So first, some observations. So a temperature of 38.5, respiratory rate of 24, oxygen sats of 95% on room air, blood pressure of 100 over 55, and a heart rate of 120. On general inspection, he is sweaty and tachypnic from the end of the bed. He looks really unwell. You look in his throat and there is no tonsillar swelling or exudate, and there's no palpable cervical lymphadenopathy. He is warm to touch peripherally. His heart sounds are normal. The pulse is regular and there's no evidence of DVT. He's got good entry in both lung bases and actually throughout his lung fields. You can't hear crackles. You can't hear any wheeze. His abdomen is soft and non-tender. For the neuro exam, you don't elicit any focal neurology, but generally speaking, he is drowsy and disorientated, but he's able to follow basic commands. He opens his eyes when you speak to him. He speaks clearly and he's able to answer questions appropriately, but he can't recall how he arrived in the hospital or what day it is. He's able to move all of his limbs. There's no rash, there's no meningism. And when you look at the hands and the feet, you note that his left fifth proximal interphalangeal joint is slightly red and slightly swollen. And also the left foot, the first metatarsophalangeal joint of the foot, is exquisitely tender to palpate. It's slightly red, but not grossly swollen. There is no palpable joint effusion that you can feel. And that's the end of the third aliquot.
Oh my gosh, you definitely have me wide awake now. And I think maybe I'll just share my quick thoughts on this, but I would love Robbie to also share his thoughts because there's so many ways you can take this aliquot of information. I think first and foremost, we have not diagnosed, we've confirmed inflammation. The temperature is elevated. The heart rate is appropriately elevated in response to the high temperatures because you have increased metabolic rate. The respiratory rate of 24, you quickly look at the lungs and you're like, wait a minute, the lungs are clear to auscultation. So there's a disconnect there, but we're not perfect at examining the lungs, meaning that if you had a positive test, then we would link the tachypnea and the hypoxemia to pulmonary pathology. But even though the exam is negative, we cannot rule out pulmonary pathology. But I'm open to the possibility that this patient has a lactic acidosis, in fact, has nothing going on in the lung, and it's tachypnic as a way to compensate for that lactic acidosis. So that wouldn't explain the mild hypoxemia. When someone's tacking away this quickly, and I know all of us have thought about endocarditis in this patient, it might be difficult to auscultate a murmur. So obtaining blood cultures and thinking about endocarditis, I think is very, very important. What was most telling about this aliquot for me is 2 additional organ systems that I'm putting in my problem list and trying to explain the unifying cause of inflammation. Remember, in aliquot 1, we first had sore throat, so oropharyngeal, and then we had some kind of thoracic inflammatory process. We don't have much more clarity on that thoracic inflammatory process beyond saying that there isn't an obvious, pleural empyema because the lung sounds were clear, or an obvious murmur to suggest endocarditis. But there's some stuff in the thorax where you can't detect on exam, and you really need that echo. You really need that troponin level. You really need that EKG. You really need that CT scan. But the 2 additional systems that we have to now put into our problem representation is CNS and joints. And joints, to qualify it even more, polyarticular joint pathology. And I would actually go on the limb and say probably arthritis because of the swelling, the tenderness, but be very, know this, that periarticular inflammation of tendons can mimic what's happening within the joint. So I have joint and now I have CNS. With CNS, the lack of meningismus does not rule out meningitis by any means. I think the confusion prioritizes some form of encephalopathy. And with the background of inflammation, you have to think about encephalitis. And whenever you say the word encephalitis, you should consider meningoencephalitis. At this juncture, with this inflammation, infection should be prioritized. So the question is, how can an infectious process involve the brain, the joints, and the thorax? Well, you can imagine some kind of disseminated bacteremia seeding multiple sites can manifest like that. And so I think in such a young patient, you really got to examine the valves. You really got to get this echo. You got to get the blood cultures. I don't think I can make significant progress beyond that. The question, of course, is going to become, with that big toe, that's classic for podagra of gout. Other diseases are less likely to involve the toe, like CPPD almost never involves the toe. The toe is cooler. meaning it's colder, so it helps precipitate monosodium urate crystals. I just read a lot about this, so but I'm not going to talk more about it. I think ultimately at this juncture, I have to ask the question. I'm going to get blood cultures. I'm going to start broad spectrum antibiotics covering CNS, covering endocarditis. Am I going to get a lumbar puncture? And here's where I think, and Robbie, this is where I would love to hear your thoughts and any other thoughts you have. If this was an older patient, 75, and came in with fever, confusion, and I got a UA and it was positive, with some urinary symptoms, I would be fine saying UTI, no need for LP. Let me treat that, see what happens. But in this patient who is so young, and I've yet to identify an etiology, and even if I identify an etiology in the bloodstream, like even if you have like a common infection, if it's involving the CNS, the treatment and duration may change. So I would have a low threshold to get an LP. So what am I doing next? CT scan of the thoracic cavity with contrast, echocardiogram, CT of the head just really quickly, blood cultures, HIV testing, basic labs, low threshold to pursue a lumbar puncture. But would love to hear from Robbie. And of course, we'll have more data to make that decision. But as any thoughts, Robbie?
Well, Prof. Rez, I have nothing to add to your diagnostic thoughts, and I'll just reflect from a management reasoning perspective that I think that you look at this case and you're like, the probability that blood cultures will be negative is low, but not impossible. And we can talk about ways to try to prevent that in a moment. But like as you said, I completely agree with you that an endovascular focus of this process is high by virtue of the fact that the simple things that connect the brain, the lungs, and the joints are something in the blood vessels. And so if we apply the most common infections that cause common infections and common locations where infections occur in blood vessels. Again, I'll just say that one more time. Like Prof. Rez is telling us brain, joints, systemic equals blood vessel infection. Where does a blood vessel infection most commonly occur? It usually occurs on the most vulnerable place. Where is the most vulnerable place? The cardiac valves. That's one dimension. What's the other dimension? What are the common organisms that do that? Gram positives, gram positive, gram positives. I would say that this patient is sick enough that you have to recognize that that's the base rate probability that this patient either has disseminated streptococcal or disseminated staphylococcal infections affecting his cardiac valves. But he's sick enough that you have to prepare for an alternate scenario. And that alternate scenario is exactly what Prof. Rez is telling us to think about, which is, does this patient have infectious meningoencephalitis? So let's review the epidemiology of the most morbid causes, the bacterial causes. And in the vast majority of immunocompetent patients, the two leading causes in this patient's age group are Streptococcus pneumoniae and Neisseria meningitidis. So not to reflect on the probability of those infections, but to go back to our management reasoning, we'll say, okay, how can I find Neisseria meningitidis? And that's when you're like, I know that the rate of bacteremia in patients who are sick with Neisseria is very high. The blood cultures are pretty good, but is there a role for pharyngeal swabbing in this patient to augment that diagnostic yield? And once you start thinking about Neisseria, you look over, you see he's in a close apartment with a roommate, and you don't know his vaccination status. You're like, okay, personal protective equipment for everybody in the room, respiratory precautions immediately when you think that, because it could spread very quickly to the healthcare workers. And then when you're like, can I exonerate the possibility of a young man whose vaccination status I don't know, who lives in close quarters, does not have disseminated Neisseria meningitidis? And I think the answer to that is absolutely not, which makes the threshold for a lumbar puncture go from equivocal to me to certain. And I think it would be really, really important to do that in this person. But do I think he has disseminated Neisseria meningitidis? No, I think the pulmonary involvement of Neisseria pneumoniae is described, but it's really, really unusual. Not to think of what kind of pulmonary involvement he seems to have. And if you go back to Prof. Rez's reflection of, is it pleural effusion? Is it air in this pleural space? Is it pericarditis? I think you're starting to wonder, wait, it's focal on the lateral left chest wall, unlikely to be pericarditis, to be focal on the lateral chest wall. It's usually mid-sternal. We don't hear a pleural effusion. So like, what is it? And that's where you start to think, could this person be having microemboli or pulmonary infarct? Now, what does that do to the calculus? it makes the probability of not just bacteremia, but an endovascular infection much more likely in my mind. Now, what's the difference? Bacteremia means that there is bacteria circulating in the blood, full stop, finish. What's the difference between bacteremia and endovascular infection? Endovascular infection means there is bacteremia and not just bacteria circulating in the blood, but bacteria sleeping and hanging out stationary and replicating in the blood. It's that static phase of growth on a vulnerable spot that can flick off pieces, occluding the circulation, potentially including the distal left pulmonary circulation, based on his symptoms. So how does that help us in the moment? Well, you're like, okay, I have to think about endovascular infection here. Where do they exist? Most commonly the heart. But where else can they exist? And I think the one place to think about very closely here is that even though he doesn't have any exam evidence of involvement of his internal jugular vein, this is a patient who I would have a very low threshold to extend that CT scan and head to also include the neck to try to capture that internal jugular vein. So for me, Prof. Rez, I'm right there with you. I think this is an endovascular infection. I think the range of possibilities are the usual gram-positive culprits, but also the gram-negatives with specific attention to Neisseria meningitidis. But then here's the final catch, is if you're entertaining Lemires in a young man with sore throat who has really critical illness, you have to remember that your empiric antibiotic therapy has to be different. So what's our empiric antibiotic therapy for meningitis? It's vancomycin, ceftriaxone, ampicillin in the right person, and acyclovir in the right person. That does not cover anaerobes, of which Fusobacterium necrophorum, the most important cause of Lemires, does not. So you might here have to change your ampicillin, not just to ampicillin, but to ampicillin sulbactam to cover for the possibility of Fusobacterium necrophorum. So you're seeing here that getting this right is really nuanced and really tough and almost, honestly, almost impossible. So these are the tenets that apply. A sick person, give them everything you can, get all the data you possibly can, and be ready to learn very quickly from the data that's coming your way. He's too sick for you to be a clinical problem solver. You should be noisy and dirty and not elegant at this point. He's a young man who's really, really in trouble. Anything else to add, Prof. Rez? I think this was a really, really powerful exam.
No, that was beautiful, man. Pure poetry.
All right, can you tell us more?
Love it. Right, I've got some blood tests and some imaging for you guys. So first of all, the bloods. You have to forgive me if these are British versions of this, the units. I will never understand the differences, so I'll give it my best go. So the hemoglobin is 116 grams per liter, which is normal. The white cell count is 18. The platelet count is 7. Neutrophils of 17. Lymphocytes of 0.7. The CRP was 240. Sodium 122. Potassium 4.5. Urea is 15.9. The creatinine is 1.65. His liver function is normal, so normal Billy. His INR is 1.3. His PTT is 56.4, and his PTT ratio is 1.7. The fibrinogen is normal. The chest X-ray shows patchy areas of opacity in both lungs and small bilateral pleural effusions. We got a CT pulmonary angiogram of his chest, and this describes multiple nodules in both lungs, and they're positioned both centrally and peripherally. There are also small bilateral loculated pleural effusions. And that's the end of the aliquot.
Prof. Maybe I can reflect on the labs, and then I know you asked for the CT, and I think it was very, very a very positive result. Hugh, can I just ask, to orient me what the normal platelet count is. So 7
Yeah,
is what we
absolutely.
have. What's normal for you?
Yeah, so a normal platelet count on our
Yeah,
machines would be 140 to 400.
understood. Okay. All right. So I think 140. Okay, so this is extremely low. Yeah, I think that uh, the laboratory signature of this disease reinforces the nature of what we're dealing with. Because if we're really strictly applying what a fever tells us the patient is acutely inflamed. When you marry acute inflammation with neutrophilic pleocytosis, you can really focus in on acute bacterial greater than fungal infections. So, of all the things that cause an acute fever, viral, drug-induced hyperthyroidism, hematological emergencies, the neutrophilia here really helps you say, unless the patient has risk factors for candidemia, all I have to think about is bacteria, 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 bacteria. The question is, what does the value add of thrombocytopenia have in this patient? And I think honestly, it's plus minus. The presence of thrombocytopenia in this patient is often attributed to the nonspecific cytokine mediated reductions in platelet counts as a result of sepsis physiology. But I wanted to share with you two unique syndromes that tend to cause thrombocytopenia from pyogenic bacteria that is out of proportion to the sepsis physiology the patient has. To hammer this point home, if you think about how many patients you've seen, for example, with endocarditis who have thrombocytopenia, not many, at least in my experience. I don't know the data. Um, probably should, but that's what we have, right? Your experience and the data. And I only have my experience right now. So I've learned this from Uncle Bob. He taught me, and I looked it up, about 70% of patients with Lemire syndrome have thrombocytopenia. I've never understood why. I'm really, really curious why. The other important syndrome to know is toxic shock syndrome. So neutrophilia here focuses on bacterial infections, but we are already there, but it reinforces that. And then disproportionate thrombocytopenia in the context of an acute pyogenic bacterial infection. Consider the possibility of sepsis being the leading cause. And then add two things as things you should think about disproportionately: toxic shock syndrome and Lemire's. And here, I think the patient has exhibited enough sepsis physiology that that is more than a satisfactory explanation. But for me, in terms of understanding where that infection's from, I'm starting to wonder, is this yet another reason to consider getting imaging of the neck? All right, Prof. Rez, mic to you.
Yeah, I think that spot on. And this is extremely helpful. This is where I'm not really deploying a schema for hyponatremia. This patient has kidney injury. It doesn't have my attention. And I think, Robbie, to add to the hypothesis of sepsis-induced thrombocytopenia is the elevated PTT. So we don't have a fibrinogen here, but high likelihood this patient's in DIC, acute DIC. I think what the CT scan does for us is critical. And it goes back to the HPI that Hugh provided. He said this patient's clinical syndrome started with a sore throat, myalgias, fever. The chest pain was mild. Then the chest pain worsened over time. So I think the story is coming very nicely together that this patient had an anaerobic pharyngitis that then, through the direct connection hypothesis that Robbie outlined in aliquot 1, that infection, which is an infection that causes phlebitis, something about fusobacterium and the milieu it creates, depending on where, whether it's in the neck or we had a case on RLR that was in the, that actually caused pilophlebitis because it was in the portal vein, resulting in thrombosis. But this bacteria loves to generate thrombosis. So this bacteria directly from the throat to the internal jugular vein. And then from there, the endovascular spread. I love the way you said that, like something there that just like flickers off. And I think this is what the lung is showing us. Like what causes disseminated pulmonary nodules? It's really, in this patient, three possibilities: a disseminated fungal infection, a disseminated tuberculosis infection, or septic emboli. This story is just too rapid and too quick for any of the other ones. And of the three bucket, the one that explains the pharyngeal symptoms that the patient initially had would be the septic emboli. It's really important to realize, like when you have endocarditis, you can make more progress by saying, is it left-sided or right-sided? Left-sided endocarditis does not cause septic emboli to the lungs. Remember, it's on the left side of the heart. Right-sided causes septic emboli to the lung. But there was no murmur. So I think the nicest way to put all this together is VMRs with endovascular infection leading to thrombophlebitis, complicated by septic emboli. And so I agree with you, Robbie. I think examining the IJ with imaging will be the next step to take. But let me throw a question back at you. What do you think about the LP now? Are you less excited and more, let's get the blood cultures, let's start the antibiotics and just see what happens? Or are you going straight for the LP?
Such a good question, Prof. Rez. I think that the LP now is a much harder thing to think about because of the thrombocytopenia, with the platelet count being so deep and the clinical syndrome. And I think this goes to show you just the power of everything that we're trying to do here. We're trying to have our clinical reasoning as good as it can be. And I think that what I would be sure about in real life is the need for a CT scan, not just of the head, but of the lungs, as you said from the beginning, and also of the neck. So I think if I'm aiming for the best possible care that I think one can try to deliver for this patient, they come in, you see their exam, they go to the CT scanner right away, head, neck with contrast, lung with contrast. And I think if I came back with the scenario that the neck is positive and the platelets are low, I'd probably not do the LP. But if the neck is negative, then what? And I think that becomes really tricky. And if the neck is negative, I would probably be calling infectious disease to guide me because I think it would be beyond my comfort level to balance the risk of an intraepidural hematoma with the risk of underdiagnosed meningitis. Because let's be clear, the tension in that case wouldn't be to treat meningitis. I think we would treat the patient. The question would be, what are the consequences of over treating the patient and giving them meningitis when they have something else? And I think that is I don't have the tools to be able to answer the question myself. So I'd probably lean on ID in real life. What do you think you would do?
Oh gosh, exactly that. I think that's such a beautiful because we're waiting for more data and that's going to guide our next steps. And I love something else you said, which I mean, I think it's just a reflection of how much you've practiced and how much you've thought about Lemierre's and how it can present. Like that point of adding sulbactam to ampicillin to make sure it's unison to cover anaerobes, like that's so nuanced, but it could be the difference of quick improvement versus, oh, do I need to do an LP because I didn't put the right agent on? And you know, the tests don't happen, like the CT doesn't, something's wrong with the CT, the patient's not taken there. So I want to applaud you. I think that for me was the highlight.
Rafraz, like you said, all that we've been doing for the last billion years is trying to do the best by our patients and like really work hard to take care of them. And that's what everyone here is doing, honestly. And who knows, in most other instances, the sulbactam would probably have caused a drug reaction. And it would have been my fault that I had given that patient that medication. But in some instances, it might be helpful. All righty, Hugh, tell us, what do you have next?
So, right, so you get some blood culture results. At least the gram stain anyway. So in your aerobic bottle, there are gram-positive cocci chains. And in your anaerobic bottle, there are gram-negative rods and there are gram-positive cocci chains. You managed to convince a radiologist to do an ultrasound of the foot and the hand. They report and say it's consistent with septic arthritis, but there's not enough fluid in either joint to aspirate. Then some more advanced labs that have starting to come back. So the ANA is negative, ANCA is negative, C3 is 38, which is low, C4 is less than 2, which is very low. The anticardiolipin, beta-2 glycoprotein, lupus anticoagulant are all negative. Oh, sorry, the lupus anticoagulant was positive, but the other tests were negative. Adams TS13 report comes back and says it's not consistent with TTP. HIV, hepatitis B, Hep C, and syphilis are all negative. The patient has a transthoracic echo and a bubble echo, and there are no vegetations and no evidence of a patent foramen ovale. And the CT neck venogram shows a filling defect in the left internal jugular vein. It extends up into the palatine, mandibular, and facial veins. And that's the end of the aliquot.
Okay, I'm glad the CT scan showed something. I think, the blood culture results are interesting because the good thing about the current era of practicing medicine is that when we have gram stains that are positive, they reflex to biofire, meaning that immediately through a PCR method, we can identify with very high accuracy what those gram stain positive organisms represent. And in this era of biofire, Carius, 16S ribosome, it's, I think, really revolutionized our ability to treat infections and understand what's driving the underlying process. So here, with any kind of positive blood culture, the question becomes, what is a contaminant and what is a pathogen? When you have it's fair game that the patient could have a polymicrobial infection that is leading to bacteremia, and each of these are true. So when I see the gram-positive cocci, I actually don't really distinguish cocci from chains because the gram stain is not perfect. I just think about both buckets, whether it's staph, it's strep species, it's enterococcus. I just think about these three whenever I see that. So I would continue covering those organisms. The gram-negative organism, I think, would be consistent with the fusobacterium. So we're going to be treating the fusobacterium. And yeah, so I would continue, honestly, what it would do for my antimicrobial management, I would be seeing how is the patient responding to decide whether I need to broaden the gram-positive coverage. But, for this patient, we already have them on vancomycin, so I wouldn't broaden beyond that. So continue the vanc, continue the unison, and then wait for all these cultures to speciate. I think the story is very good for Lemierre's, but I think the joint pain and septic arthritis, that's not part of my illness script. I would have to look to see if it could be. And then with the gram-positive being positive, I'm curious to whether you actually have gram-positive bacteremia as well. And the question becomes, where is that source? The TTE didn't show anything. But yeah, I think right now, Hugh, what I'm confident in is that we have Lemierre's because of the IJ filling defect, the septic emboli. What I'm less confident is whether we have an additional bacteremia, primarily because of the arthritis. I don't think this is APLS. Yes, that can present with thrombocytopenia and a high PTT, but I already have a better explanation for that. And just one positive lupus anticoagulant during an illness isn't enough. And the APLS, you get thromboses in rare areas, like you can get Budd-Chiari, you can get a renal vein thrombus or cerebral vein thrombus, but it doesn't really cause this sort of thrombophlebitis that we're seeing in the IJ with the sore throat. Robbie, what are your thoughts, my friend?
I couldn't agree more with you, Prof. Rez. I think that the rest of the findings are very compatible with Lemierre's, and I think the ongoing question about that dimension is source control, source control, source control. And so a lot of people discuss the value of anticoagulation just for source control. And here, I think a big gap in assessing source control is looking at the abdomen in this obtunded patient who can't tell you if they have a hepatic abscess or a splenic abscess. In terms of the microbiology, I think it's really interesting. Polymicrobial Ramirez, I had the chance to read about it after a case that I discussed with colleagues in Japan and learned from them, from their teaching, that that polymicrobial Ramirez occurs in up to 10% of patients with Ramirez, and the usual coexisting pathogens are streptococci. And when you hear that, you're like, oh, you know what? Wow, now that somebody gave me that knowledge, it makes sense because the oral streptococci live in the pharynx. And I learned from them that it's usually not group A strep, which I think we worry about, but it's the other group streps, like group C strep or group D strep. So I think I'm just humbled by this disease, which I think we can confidently call Lemierre's, but curiously wonder what the culture results are, how it can take, we were wondering, like, why would a young, otherwise healthy person be here? And I think that question now has been answered. And the answer is we don't know. We don't know why Lemierre's can take a normal, otherwise healthy person and leave them requiring such intense care. But yeah, Prof. Raz, my analysis of all the other data is identical to you. I'm not sure if this patient has APLS. I don't think it's acutely relevant. I would probably scan his belly, but keep the antibiotics like they are, as you suggested. All right, Hugh. Mike, to you for more information or whatever you had planned.
Lovely. Yeah. Thanks very much, guys. So this is, I'll reveal the diagnosis. You'll be pleased to know you're barking up the right tree. And then I'll give you a bit of development about what happened. So the patient's blood culture results grew in the aerobic bottle Streptococcus constellatus, and in the anaerobic bottle Fusobacterium necrophorum and Streptococcus constellatus. So this patient was diagnosed with Lemierre's syndrome with septic thromboembolic metastases to her lung and septic arthritis of the small joints of the hands and the foot. Lemierre syndrome refers to septic thromboembolism caused by infection with Fusobacterium. It's classically associated with pharyngitis, tonsillitis, or a peritonsillar abscess. The most common organism is Fusobacterium, as we've mentioned, an anaerobic gram-negative rod. And the most common sites of embolism in order are the lungs and then the joints, first and second. So for this man, so in the first 48 hours of admission, he was initially treated with IV fluids, broad spectrum antibiotics. Much like you said, the treatment had to come first before the diagnostic reasoning. And he was actually given a single pool of platelets at that time. After the CT pulmonary angiogram and the gram stain were reported, we did add anaerobic cover. And despite that, a day later, he was admitted to ITU for high flow nasal oxygen. And then between days 2 and day 7, he had a repeat CT of his chest, this time including the abdomen. And it revealed increasing size of the cavities and bigger pleural effusions. He suffered with respiratory failure. He was on high flow nasal oxygen for a week, but never required intubation and ventilation. The clotting factor abnormalities and the thrombocytopenia and the decisions about whether to anticoagulate, I think we should maybe leave to a discussion. So I did leave a note about that, but I think I'll just stop there for a second. And then the last thing to say is that the thrombocytopenia normalized over a period of about 5 days, at which point oxygenation was much better and the patient was stepped down from ITU. Yeah, I think I'll leave it there for now.
That's such a humbling case, honestly. And I think that I'm so glad that you guys were able to recognize the syndrome very quickly and that the patient had a tumultuous, but thankfully a very meaningful outcome. I have so many reflections tossing in my mind, a lot of reinforcing to do for sure, and learning a little bit more about the overlap of the Strep milleri group infections and Fusobacterium. I had categorized Strep constellatus, which is part of the Strep milleri group, and Fusobacterium as very distinct syndrome. I'm always humbled in medicine how things that in my mind are separate are actually related, as your case clearly demonstrates. But I think my favorite and most telling moment was in Aliquot 3 when you had asked Prof. Rez to analyze the exam and he said bloodstream infection. And I think that tenet is just really, really important to recognize, and ultimately becomes a question of what causes bloodstream infections. In this case, I think reinforced a rare manifestation of that, but one that's not surprising to affect a young, otherwise healthy person. So if we really say what causes bacteremia in a young, otherwise healthy person, then you start to wonder, I don't know what the base rate is. But then you apply with pharyngitis. I think this case really enforces that this rare scenario, if it shows up, I don't think there are many other possible alternatives than this devastating disease. Profres, what are your thoughts or reflections?
I echo that, and I just want to take a moment to thank you for putting this case together, for sharing it with us, and how humbling it is that an infection can take someone who's so healthy and put them at death's doorsteps. But with your intervention and the stellar care you guys provided, you brought them back. So congrats to you and your colleagues there, Hugh.
I played a very small role. I was working with some excellent doctors. Uh, Listen, and in terms of putting the case together, just shout out to Yusuf who helped me put this together. It's been a joy being here, and something I've looked forward to for a long time. Um, in some ways, I'm sad that I don't have more complex cases or interesting cases to share, but I'll definitely be back.
Well, we would be thrilled to have you, Hugh. I think that honestly, I really hope you'll consider presenting your UTI case or your bread and butter. We miss those. We don't benefit from the fascinating clinical reasoning that happens in those spaces too. I trust me, I find it. You heard Prof. Rez reflect on the pathophysiology of gout. He couldn't help it, and I think we love the bread and butter just as much as we love the esoteria. So thank you. Really appreciate your time here.
Hugh, before we pass it to Kuchal, do me a favor, unmute yourself and say, welcome back, clinical problem solvers.
Welcome back, clinical problem solvers.
Robbie, I'm going to take that snippet and put it in front of RLR.
Hugh, judging by the style, the form, and the delivery, I now it's now been confirmed you've been listening for a long time.
Oh yeah, don't worry, never in doubt. When I met with Yusuf online, and I said, and we were talking for a few minutes, and I just feel like I've sat on the other end of the camera so many times. I would be a fool to mess this up.
Well, we hope you sit on this side of the camera a lot more. We really do. Alrighty, Kushal, Mike, to you for the teaching points.
Amazing case and the important point which I learned was that the patient having fever and just it translates into inflammation and then sore throat and mouth, yeah, chest pain, all the other symptoms the patient is having, and then just see which organ it's pointing towards. In this case, it's either the thoracic, the lung, or the heart, or other mediastinal structures. And as the case is going on and that being presented, the patient was having chest pain, think of all the P's, which is going to be either the pulmonary embolism, pericarditis, pneumonia, or pleuritis. So further investigations like CT chest, EKG, echo, troponin could help further differentiate between these structures. And since the patient in the chat, others were mentioning that cannabis, since he was smoking, there's increased risk of either fungal or heavy metal poisoning like cadmium. And if the patient is having a negative exam, it doesn't rule out the infection is still in the pulmonary source or endocardium. So it's important to do a blood culture to rule it out. And given the patient's age, as well as other symptoms to be added in the problem representation would be either the joints or the brain or the structure which is connecting all of that, which is the bloodstream or the blood vessel rather. And this patient, in the lab, there was thrombocytopenia. And if the patient is having a thrombocytopenia with this in a presentation, we would have to think of 70% of the patients either as Meniere's disease or toxic shock syndrome. And someone mentioned that rash isn't can't present much later in a patient with toxic shock syndrome than earlier. And that's something which needs to be considered. And in case of polymicrobial Meniere's disease, it's more common to do with a strep group C or D than with the group A strep. And with the last, there was a pulmonary nodule, and we're going to think of either disseminated fungal infection or septic emboli or a disseminated TB. And if there's a positive blood culture, and if you're got to consider whether it's the actual pathogen or if it's a contaminant. And yes, and the other thing which I learned was the complements are usually decreased in endocarditis or the endovascular infection.
Absolutely superb, Kushal. That was not an easy case to digest and reflect. And thank you for highlighting the key things along the way. Hugh, thank you again for an outstanding case. Very, very memorable. Will live on for a lifetime, honestly. And I'm trying to remember. Oh, actually, no. Tomorrow is an Academy VMR, so hope to see all of you on Sunday for a fundamentals of clinical reasoning exercise. All right, y'all have a great day. Bye, Hugh. Bye, Prof. Rez. Bye,
Thanks so
everyone.
much. Bye.